Hi everyone, I'm Dr. Lucky Seacon and I'm doing an Instagram Live today with a dear close friend of mine and a colleague, Dr. Lee Rosen. She is one of the most fantastic GYN surgeons in New York City and she works at Mount Sinai. We did our residency at Mount Sinai together and I see you, Lee. Let me get you in here. Hold on a second. So we did our under so many of my patients, especially for issues like Asherman syndrome, which we're going to be talking about today. And we're going to talk about what that is in a second. Hi, how's
Hi.
it going?
Great.
Why did we wait so long to do this?
I don't know.
Hold
I
on, let
don't
me turn
know. So
up my volume. I can't hear. My volume was like way low. Hold on. It's where my phone is being. This is a fail. Hold on. Okay. Say something.
can you hear me?
Yes. Can
Okay.
you hear me?
I can hear you.
Okay. I'm all mic'd up for you. I got fancy. How's
I
it
am not.
going?
I am not.
It's okay. You'll get there one day. So the last time we did this, I feel like we were like, oh, we'll do this every 2 weeks. And then a year went by. But I still have people tell me how helpful our live on fibroids was.
Yeah.
And I'm not surprised because I feel like you and I have a very similar communication style and we're pretty much straight shooters and want people to understand everything. And I think we're good at breaking things down. So this is a hard topic, but this is like your area of expertise. And I send so many patients with this problem to you. So thank you for agreeing to do this live all about Ashermans.
Happy to. So happy to be here and talking about this. It can be very, very frustrating condition
Yeah.
that allows so many people who have it. So I'm happy and excited to talk about it and hopefully provide some good information.
Am I catching you at the end of your day or done with the OR?
I am.
What type of cases did you do today?
Bunch of different things today. So we did some hysteroscopies as well as some other cases.
Okay, cool. Well, we're going to be talking a lot about hysteroscopies today. I guess we should start by defining Ashermans, which
Right.
I'll let you do
Sure.
and I'll jump in if I need to. But in general, like, how do you explain it to patients when
Sure.
we think that they have this diagnosis?
So I describe Asherman's as essentially being scar tissue that forms inside the uterus. And sometimes it doesn't cause any symptoms and you have no idea that you have it, but symptoms or signs that you can have it include changes in your period. So your period might become much lighter, you might stop getting a period, you might have more cramps or more pain with your period than you did before, and you also might have difficulty getting pregnant. And so, that's kind of the setting in which it's found.
Yeah, I think a lot of people freak out when they hear period being lighter or don't get a period. I want to make sure people understand that if they've been on really long-term birth control, that's different. If they have a Mirena or a progestin IUD, that's different. Those are normal causes of your period getting very light. And it's just because you don't really have the opportunity to build up your lining.
Right.
But if you're not on these types of forms of contraception, or you aren't just coming off of long-term contraception, um, seeing a change in the pattern in terms of the intensity of bleeding or the amount of bleeding, the number of days, all of that can be a telltale sign that there's something going on with the lining, whether it's scarring or something else that's preventing you from having that normal
Right.
period.
And that's true. I mean, it's a great point. I feel like I meet people often who say, my period's gotten lighter. Does this mean I have Asherman's? No, that doesn't mean that. Sometimes your period just changes throughout your
Right.
lifetime, right?
Right.
But I think in particular, if you, in your experience, if you had a procedure on your uterus, for example, that and in addition to that you notice these changes in your cycle, it doesn't mean you have this, but it means something that you want to be aware of.
Yeah.
Like,
I feel like if you had to rank the highest risk elements of someone's medical history that
yeah,
makes you feel suspicious, not that I want people to panic
right,
because any of these things applies to them, but if someone says to you, my periods are lighter, they've stopped coming, and I had XYZ happen in the past, like what would you say is the most likely thing on the list versus like lower
Sure.
down in terms of your level of
So
concern?
one of the biggest risk factors is if you had what's called a D&C immediately after you had a baby,
Mhm.
immediately postpartum. So this can be, this can happen if you had a lot of bleeding during the delivery or retained placenta after the delivery. That's probably the biggest risk factor. Again, if you have to, when this happens and you have to have it, it doesn't mean you're going to get Ashermans, but it definitely is, I think, the biggest risk factor in terms of potentially getting scarring in the uterus. And then after that, any, just multiple surgeries on the uterus can be, not necessarily in the postpartum immediately after delivering a baby state, but multiple procedures on the uterus. And then there are some kind of other risk factors that are a little bit less common, like certain types of infections.
Yeah, like
Yeah,
tuberculosis, which is not common here,
correct.
thankfully.
Yes.
Um, Fibroids, I find when people get a hysteroscopy to get fibroids removed, it's often presented to them as a very minor procedure. And for the most part, I think it is. Are there times where you do something preventative after taking out a fibroid,
Sure.
even though you're not doing an abdominal incision, you're just going in with the camera? Hysteroscopy, for anyone that's not familiar, is basically when you go through the vaginal canal and the cervix with a long, thin camera and you look inside the uterus and you're able to rectify or remove things like polyps, fibroids, scarring. And so people will often say, oh, I have a fibroid. It needs to come out because it's in the lining. It could affect my fertility. It's causing heavy periods, whatever. And you don't always do something to prevent Asherman's, but when are you concerned and when do you think people should be asking their doctor about this if they're just having this simple procedure to
Yeah.
remove a fibroid?
Yeah.
Um,
So
what's the concern?
So for me, if you have multiple fibroids and it's requiring extensive, a more extensive procedure, especially like we think about the cavity, the inside of the uterus as a space, and if you have multiple fibroids on opposing surfaces and you are removing the fibroids at once, that could be more of a risk factor for, or I would worry a little bit more about scar tissue and might do some things during the procedure to help minimize that risk. One of the other things I want to mention is pregnancy alone is a risk factor, just having been pregnant ever.
Yeah.
I will also say that I feel that I have seen more recently people who have developed scar tissue without any identifiable risk factor. And so, I don't know. I just wanted to make that,
Yeah.
make that clear.
I've seen that too, where I am like very psychotic, as you know, about doing a saline sonogram within a certain time frame before the transfer. I'm very meticulous. And you see sometimes these adhesions, and you're like, have you ever had a procedure?
Yeah,
Has there ever been anything inside your uterus? I have no idea why that happens. And sometimes I wonder if I'm overly stringent and sometimes it could be like the endometrium. But there's been times I've sent these patients to you and you're like, no, they had some filmy adhesions and I took them down. And I always feel like things like an embryo transfer are very high stakes. It's very rare that I've seen really dense adhesions or real problems that
correct.
have no identifiable history associated with them. But yeah, sometimes it's unclear. And I've had patients with, I think IUDs are great and they are a reversible form of contraception, but I've had some patients where, maybe the IUD was embedded and there was
Right,
some trauma, anything can happen.
right, for sure, for sure.
So let's talk about, oh, by the way, while you were talking, I drew it out in case anyone would find this helpful. So this
Thank you.
is,
Those are the opposing surfaces. That's very
yes, this is the vaginal canal, cervix, inner cavity of the uterus. So let's say you only have one fibroid, and if it's not taking up a lot of surface area and you were just to shave that out, you probably would not put a balloon or anything to keep the walls apart while healing is taking place. But like you said, if you're doing it here and then here, I always say it's like if you have a cut and you don't put a band-aid on it and your clothing kind of sticks to the
mhm,
scab as it's like healing. Do you know that
yeah.
feeling, or am I the only freak
No,
that's had that
but that,
happen to them?
no, it's true.
Okay.
That's
Because
true.
I'm like that healing and cell turnover, all of that makes it kind of sticky. And so it's more prone to sticking together. And everything you said about postpartum being a risk factor, I don't know what it is, but the pregnant and postpartum uterus are just so delicate.
Yeah, that,
The lining of the endometrium is so delicate, and it's the basalis layer that if that undergoes trauma or disruption, that's where the scarring typically comes from.
yeah. I mean, that's the bit that really is the biggest risk factor. I mean,
They say
I
the
mean,
first month within postpartum,
correct.
if you have a DNC, it's like a 30% chance that
Yeah.
you could have some scarring. So
Mm-hmm.
it's scary, but obviously if you're in that situation, there's a reason you're getting it done. And
Oh,
um,
yes. Thank you for saying that. I think that's something I really, people will come to me and will figure out that they have Ashermans and they have scar tissue, and they're like, well, if I hadn't done this DNC, or if I hadn't done this, that's
you
irrelevant
might
because
have hemorrhaged.
correct.
Yeah,
Or at the time, that was the best approach that needed
right.
to be taken to
Yes.
address the issue. And plenty of people have multiple procedures on their uterus and DNCs and this and that, and they don't get scar tissue. So
Yes.
I always say, I find that that's something that is really important. That this isn't, you aren't like choices that you make in these situations that result. It's not your fault
We
that
don't
this
want
happens. It's
this live to cause situations where people are like, look at these Instagram doctors and what they said. I don't want you to do this. If it's something that you need to do for your health,
do it.
especially if you have like retained tissue from a pregnancy loss, like that can cause infection and other
Correct.
issues. And especially if you're bleeding, it's necessary.
Exactly.
I had two really quick thoughts that I don't want to lose.
Yeah.
I think I'm already losing one of them. Uh-oh. One of them was, shoot. Um, Retained tissue, right? Because we talked about postpartum.
Yes.
There is something to be said, though, about the way to deal with retained tissue, because a lot of times there's two options, right? You have leftover tissue for whatever reason, and whether it's a piece of the placenta or from a pregnancy loss, there's still fetal tissue and pregnancy tissue inside the uterus. There are some people that might go in and just do a general scraping of the uterus, like a DNC, and just say,
Right.
like, just get it out, kind of blindly, but
Right.
just by feeling it. And then some people that will go in with a hysteroscope and look under direct visualization and remove what needs to be removed and leave most of the rest of the cavity undisturbed. So there's
That's
actually studies that show a much higher rate of Ashermans with the first option that I talked about versus if you do a focused removal of the tissue with a hysteroscope.
exactly. And that's why whenever I'm in that situation with a patient, I always say the goal is to try to do it the second way you describe, which is where you go in with a camera,
Yeah,
you look around and you essentially grab the retained tissue and you don't touch anything else in there.
right.
Sometimes that's just not possible. And the reason is
Yes.
mainly because the retained tissue can bleed. And if there's bleeding, you can't see, and that it doesn't work. So,
Yes.
that's something that is, yeah, great point.
The reason I send all my patients to you is because I feel that there are certain people that have a true understanding of how delicate the uterine cavity is, especially when it comes to trying to conceive and preserving fertility. And something that I've noted is that everyone does things a little bit differently. And even getting like a simple polyp out, I remember early in my training, it was kind of like normal to be like, take out the polyp and then do a DNC. But you have to think about who you're doing this on. If it's a postmenopausal woman with a polyp, it's actually important to probably do the DNC to collect all the tissue and make sure they don't have other issues like early endometrial cancer and things like that.
Yes.
But if it's a premenopausal woman who is going to try to get pregnant and you're just trying to take out a polyp, you can do that hysteroscopically in a focused way without then doing this like global scraping of the uterus. So PSA to anyone watching, when you're talking to your surgeon or your GYN about how they're going to do this, ask about that and say, I want to have just the polyp removed and that's it. Unless there's a reason to do a DNC, not everyone needs a DNC at the time of polypectomy and at the time of getting tissue removed.
Right. Correct. Yep. Totally.
I forgot my second point, but no, it'll come back to me later. My next question for you is, can you talk about the range?
Yes.
Like you see really
Yes.
mild and then you see really severe cases.
That's yes. So it's not there is a massive range, and there's very minor scar tissue that honestly someone might miss without kind of knowing to look specifically for it. And then there's really severe scar tissue where there's essentially no recognizable cavity or center of the uterus. And so those are completely different situations in terms of what that looks like moving forward with trying to get pregnant. And so I factor in a multiple different things. So it's like, what are the adhesions? What kind of adhesions? Are they filmy? Are they thin? Are they thick? How much of the cavity is affected? Is it a very small portion? Is it half of it? Is it the majority? And all of those things kind of factor into whether or not I feel like we've got a minor situation, a moderate situation, or a severe situation. That degree, of severity kind of determines how likely is it to come back, because it can come back. How hard is it going to be to get pregnant after, you are in this situation?
Yeah, I think a lot of people find it confusing when they're like, well, why can't you tell me that? And I'm like, well, I did your saline and I can tell you where there are adhesions. Basically, by looking at the silhouette of the uterine cavity, I can tell, if there's like a band of scarring, because when I inflate the cavity with fluid, I can see that that's casting a shadow and taking up space. But I can't see what the actual surface of the uterus looks like. And that's where you come in, and I'm anxiously waiting for you to text me and show me pictures and share what you found, because how much blood flow does it look like the lining is getting?
Right.
So like, is it white?
Yes.
And it looks like just paper thin and there's nothing there? That's less encouraging versus someone who has a nice pinkish, reddish, there's a lot of blood flow and there's a lot of potential for healing and for it to kind of get restored to normal.
Totally. That's like, yeah. I mean, you really can't say, in my opinion, without looking at the actual endometrium.
Right. I think no two cases are ever the same.
Exactly.
Right.
No. Yeah.
And the hard part is people Google, and Ashermans is very scary on Google.
Yeah.
Right. Because people are like, oh my gosh, my uterus is ruined. It will never, ever be normal. And you and I can attest to all of the shared cases we've had, even where you went in on the hysteroscopy, we were both like, there's a lot of scarring and we had to do a lot.
Yes.
And people have gotten pregnant. So there's a reason to be hopeful.
Yeah.
But it often takes more than one procedure.
Yeah.
Can we talk about that?
Yeah, it does often take more than one procedure, but the way I view the benefit of, the way I determine whether another procedure makes sense for me is if I feel that a procedure made a difference at all. So if I do a hysteroscopy and I find scar tissue and I get rid of it, and then, maybe later down the line we find that more scarring has occurred or has been identified, I do another procedure. I want to feel confident that it's better than it was before.
Right.
If I do a second procedure and it looks just as it did before I did my first procedure, or it looks worse, then that's not a good sign. That's not a good indicator to me that there's really much to be done in a way, right?
Yeah.
So it can take multiple procedures, but you want to feel like you know that each procedure is making a difference.
Yeah, it's almost like you're chipping away at it little by little. And sometimes baby steps is better than doing anything crazy and drastic.
Mm-hmm.
You always want to be safe and you don't want to be too cavalier, because remember, every procedure, every snip or incision that you're making is another potential opportunity for scarring. So I know a lot of people would love to come to you, but they may be in different countries, different parts of the country. What are some key things that you think, as an expert in this area who's done so many of these procedures, what are things that you try to do to minimize the chance of recurrence and to maximize the outcome so that people potentially can minimize how many procedures they may need in the future?
Sure. So when I do these cases, as we talked a little bit earlier, I do a hysteroscopy, which means a very small camera goes inside the vagina into the uterine cavity. And I first just do a global view and I look around and see what's going on.
Mhm.
I have a tendency to use little scissors. They're called hysteroscopic scissors, and basically the hysteroscope is like a camera, and there's an opening where I can pass an instrument through the camera that allows me to do the surgery. And so I prefer to use scissors, which are, there's no heat, there's no energy, there's no burning. It's just, they're called cold scissors. And I essentially try to restore the normal anatomy or the normal shape of the uterus. I try to identify the ostia, which are the openings to the fallopian tubes. And then once I feel like, I've restored it as good as I possibly can, at the end of the procedure, I will leave a intrauterine Foley,
Mhm.
which is basically a little balloon that I leave inside. I was going to bring one, and of course I didn't bring it, but to show you, it's a little balloon that I place inside the uterine cavity, and I fill it up with fluid, so it's kind of like a round shape that keeps the shape that I just tried to achieve by getting rid of the scar tissue, and it stays in place for at least a week if you can
Mhm.
go with it, because it's not very comfortable, let's say. And then I will give my patients estrogen, which take for a period of time. I usually am working with a fertility doctor and REI as well to kind of coordinate this.
Only me, right?
Only
No, I'm just kidding.
nobody else, only the best. And then yeah, and then that's it. And then I usually recommend a repeat, either a saline sonogram or some sort of additional testing to assess what's going on. Some other doctors will do a repeat hysteroscopy to look and see. Um,
Mhm.
so
So when
it,
you and I do these cases together, the coordination of care is really important, right? Because another thing that is worth mentioning in terms of strategies to minimize the chance for reformation of scarring is the temporal proximity, the
yeah,
timeline from when you do the procedure and then when we actually try and get you pregnant. So if we're doing this in preparation for an embryo transfer,
yes,
a lot of people are like, oh, am I going to need to heal and wait for like 3 to 6 months? And I'm like, no, 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 opposite. I actually want to move forward fairly
yeah,
quickly because, in my experience, the longer we wait, the more time there is for the scar to come back.
absolutely,
And then you're kind of chasing it.
exactly. And that's another point I think you and I have spoken about. If I've met patients who find out, or we figure out they have Ashermans and they're considering surgery, and they don't have a fertility doctor, you working with them, then I make sure that they do, if you're trying to get pregnant, because it is a little bit of a dance, I think, in terms of
Hmm.
ensuring that everything is optimal. It's just everything's very,
Yeah. It's dynamic. It's always changing. And that's the thing that frustrates people. They're like, what do you mean I need to do a saline sonogram? I had an HSG a year ago or 2 years ago. And I'm like, a lot can happen in that
yeah,
time, even beyond scarring. You can grow
yeah,
polyps, fibroids, and always need to reassess. Um, in my experience, seeing second opinions and whatnot, like there are lots of people with under recognized uterine factor issues because there's this lax way of thinking about, I already looked at the uterus and now you're good for a year. It's like, I don't know. I think you need to be constantly reevaluated. I'm not suggesting you do a saline at once a month, but
right,
if you're doing a transfer, it's high stakes. I would probably repeat it if it's been over 6 months. And it really depends. Are you someone that normally gets scarring,
yeah,
polyps? Like, then you should probably do it more frequently than
yeah,
that, potentially.
yeah,
I'm pulling in some questions for my stories. I know we said 30 minutes. Do you have time for like
yeah.
a few questions that people sent in? Okay. What's the range in your experience, the number of hysteroscopies you've seen needed before someone could get to transfer or had success? Just like roughly speaking, like what's the minimum? I guess the minimum is one
Minimum
hysteroscopy.
would be one. um Maximum, in terms of, I don't know, somewhere between 5 and 10 would be a high number of cases. It would have, in those, once you're getting up to those numbers, it really has to be, in my opinion, you have to be seeing improvement with everyone.
Yeah.
I think the
Would you
average. one.
Would you say you've had patients in that range then eventually be successful?
A couple.
Yeah. I feel like once you're getting past 5, it's like that's a sign that there's something else going on. But I think every case is different, like you said, so it's kind of hard to speak
Yes.
in general terms about this. Someone asked, if you get pregnant with small adhesions, what is known about the obstetrical risk? I know we don't, neither of us practice OB, but we know about like the general
So there's
things that
really,
you might be at higher risk
yeah.
of.
So when I operate on someone and we, confirm they have Ashermans and we treat them for it and they get pregnant, one of the things that we tell them to look out for, and their OBs will look out for, is essentially having the placenta be stuck to the uterus, adherent placenta. I think there's about a 10% risk of that happening. I mean, again, it depends on how much, what are we talking? Very mild scar tissue versus more severe is, again, very different. But that's one of the things specific to pregnancy.
Okay. Someone asked, hold on here. Oh, wait, no, that's the wrong question. We already answered that. Someone asked if there is tips or ways that we can try to avoid it from happening if they've had a miscarriage. I would say,
Uh, no,
like, don't be over the top aggressive.
I mean,
I always try to do the least amount possible. You know what I
yeah,
mean?
but I
So, like, if,
also, again, like a lot of this is just bad luck,
yes,
and that's so important. It's, yes, there are certain things that put you at risk for developing this, but the majority of people who go through all of these procedures and all of these things don't get it. So it's just, sometimes it's just bad luck, and I think that's so important. But
yes. Yeah, like people have said it's constitutional, meaning plenty of people have miscarriages and then require a DNC, or maybe they want to get the DNC to expedite recovery or to do genetic testing. I've done DNCs on patients. Like, I don't think that it's a reason to avoid doing that. But there are certain patients where I'm like, they had scarring and we fixed it, and now they've had a miscarriage. Like, I'm less inclined to be like, let's jump straight to DNC. If I can treat that medically,
I
I'd prefer to.
absolutely,
Like,
absolutely,
less is more. But I would also say, using medications like Cytotec, misoprostol, mifepristone to actively manage, a early first trimester miscarriage, so that you don't find yourself in that situation where you might need a DNC. I don't know. I don't think it's always avoidable. I think what you said is exactly correct, that there's also some people that have underlying, it could be your genetic makeup, it could be environmental. And then I think the procedure too, I think making sure, this is why I send all my patients to someone I know and that I trust, and I know how they're going to do things, and they're going to be very gentle. I think there is something to be said about people that have a specific focus on fertility.
yeah. Yeah. I mean, I feel that way.
Okay, let's see. I have a few more questions. Um, how long after having scars removed can you start trying again? What do you tell patients?
Well, I think I like kind of what we talked about already. I would advise, I mean, if you have scar tissue removed, you're going to most likely get some post-surgery medications or medical
Yeah.
treatment. And once that's finished, I would advise trying.
Yeah. Okay, cool. Let's go through the comments that people put in the live here. Let me just scroll through and then I think we'll wrap up. Someone said, I had a second trimester loss, 19 weeks back in May, planning an FET. Recently did a biopsy and still want to transfer the cycle. Is it okay to go ahead? So someone else asked a question about this. It might have been the same person. They were asking about an endometrial scratch and if it's the same as like a DNC in terms of the risk of adhesion. So someone having an endometrial biopsy, which used to be really popular in my field, because there was this idea that inducing some inflammation might create an environment where it's more likely that the lining could accept the embryo and it would be more likely to work. That's been debunked, but I know some people still try using that. But like an endometrial biopsy and a DNC are two
Yeah.
different things.
Yes.
So I would not worry about getting Ashermans after a biopsy. I think I think we answered all the questions. We did a great job. We're only 5 minutes over.
Yeah. How do you, are you getting them? I don't even know how. I'm like looking. Am
Through
I
the,
supposed to see
the
the question?
comments, and then also I had a question box that I put up earlier, and if you click on the little
Oh,
round circle with the
like
questions, it shows up.
really?
I'll show you all my ways. This was super helpful and high yield. If there's any other questions that we didn't address that come to mind, I think you should put them in the comments because I'm going to post this to both of our grids on our Instagram, and we'll definitely chime in and answer in the comments. And if you have any suggestions for future topics for us to talk about from the perspective of fertility treatment, GYN surgery, let us know because we're definitely going to not wait another whole year to do the next topic. And definitely follow Dr. Lee Rosen. She is based in New York City like me. And if you ever need anything GYN surgery related, she is the person you need to go to.
Thanks, Lucky.
I love you. I miss you.
Me
All
too.
right. I'll see you soon. Have a great night. Bye.